So I'm Jenny, one of the leads of these studies that we'll be talking, Katie and I will be talking across in terms of challenges. So across 3 studies, actually, we're trying to describe and evaluate health visiting and its variation, including in costs at a national level. So just the description is quite a significant task in itself. Then we have 2 approaches to quantifying impact. So in one study, we're trying to create a taxonomy, so a series of models to describe how health visiting is delivered at an area level. We can come back to that later. And then comparing child and maternal outcomes between areas at an area level. So that's an ecological design. And in another study, we're quantifying the frequency and type of health visiting contacts for individual children, and then comparing outcomes between children that are matched on need characteristics. In one study, we're focusing specifically on a subgroup of children with a very specifically designed set of adverse circumstances related to drugs, alcohol and violence, among them alcohol, drugs and violence admissions in mothers admitted to hospital. In all of these studies, we're comparing with taking advantage of naturally occurring variation, which I'm sure we'll go on to discuss, to create comparison groups. And we're using routinely collected data, so administrative data and in-depth qualitative methods. So there's no changes to health visiting practice as part of the study and no primary data collection. The challenges that we're discussing today were in part identified through stakeholder engagement, as described here. We're going to talk through 3 main challenges, and the first one is about the intervention. So what is the intervention, in this case, health visiting? So as most of you will know, health visiting is a universal service for children under 5, and the Health Visitors Lead the Healthy Child programme. We're focusing on England. Health visitors work in skill mixed teams, so health visitors with staff nurses, nursery nurses, sometimes early years practitioners or senior practitioners, commissioned by the local authority, sometimes provided in-house, but often provided by the NHS. It's a complex intervention, lots of moving parts, and taking place within a really complicated system. In terms of contact with families, in England, there should be 5 mandated contacts, 1 prenatally and 4 postnatally up to the age of 2.5, and additional contacts where needed. So that's a service structure. But what's important here, I think, is that at the heart of health visiting, as you'll know, and the heart of health visiting theory is the relationship between parents and health visitors. So that really underlies the mechanism of change. So you can see here that one of our key informants described health visiting as relational support and someone who's got your back. And the parents in our workshops were again and again vocalised the value they placed on the support and empathy without judgment from the health visitor. So we need to keep this fundamental feature of health visiting in mind as we go forward, thinking about what we can measure and how we can evaluate health visiting. The second complicating factor is, The second complicating factor is that the health visiting offer is highly variable across the country. And one of our key informants said, you know, you're going to get there 152 local authorities, and there's going to be 152 ways of, you're going to get 152 ways to deliver it. It varies organisationally, so in terms of the provider, in terms of delivery, so who's delivering the contact, which of those staff members that I've described, and of course what happens in those contacts. And what happens around the contacts, both administratively, but in terms of the other services that are available to refer to or to support within the Healthy Child programme and beyond. So high variation. And lastly, on the intervention, one of our key informers asked us a question, which was, what answers will you get from an evaluation about the impact, an evaluation of health visiting, if you're evaluating a broken system? So this key informant was referring to the well-documented, and I'm sure you've experienced some issues in health visiting with, as Sam mentioned, problems with insufficient workforce, stretched budgets, rising need, that makes it difficult to deliver both universal and targeted contacts, and to provide the nuanced and relational, empathetic, holistic support, which is at the middle of health visiting, at the heart of its theory of change. And that's something that came up again and again and again and again, with policy colleagues and key informants wanting to know the answer, not only to the impact of health visiting now as delivered, but what health visiting could achieve if it was more resourced and more optimally resourced. Over to Katie.
Thanks, Jenny. Okay, so as Jenny has summarised, it's difficult to describe what this intervention, what health visiting is, because it's so complex. But if we're going to try to evaluate it in some way, then we need to be able to quantify it at a national level. We do have some information on health visiting contacts that's captured nationally. A dataset called the CSDS, Community Services Dataset. It's an administrative dataset collected by NHS England, containing data since 2015. So in theory, we should be able to use the CSDS to see every contact that each child in England has had from around 2018, when the data quality began to be acceptable. We should be able to see where that contact took place, so at home or in a clinic, and the duration of the contact. But if you want to click through, Jenny, there's no information on who delivered the contact. So we don't know if it's a health visitor, a staff nurse, a nursery nurse. Because as with many variables in the CSDS, the information should be collected, but unfortunately is missing. So we don't have information on why they had a contact, especially for additional contacts over and above the 5 mandated ones. And we don't have information about what happened in the contact. So it's quite far using this data from the component that health visiting that everyone says is what matters, the care and support and the relational work. The best we can do with the national data is really to use the coverage, so the percentage of children who receive their mandated contacts, who receive additional contacts from a health visitor, and the frequency of contacts as a sort of signal of opportunity to deliver health visiting, even though we don't know what's been delivered, the quality or the content of that contact. There are measures of health visiting delivery that are captured and published at a national level in aggregate for local authorities, and these again are the coverage and the timeliness of the mandated contacts. So these are published by OHID, but they aren't the most useful metrics with which to evaluate performance. Okay, next one, Jenny, please. So one of the challenges with CSDS is that it's incomplete and it's geographically variable. So these plots show the coverage of each of the postnatal mandated contacts for each local authority. So the grey areas don't contribute any data over this 2-year period, and not all of the local authorities submit consistent data. So we might look at some areas and that seem to have high health visiting coverage, but we have to take into account that the amount of data that they've contributed. There are lots of reasons why the data are incomplete, but the main one seems to be just about the incompatibility of IT systems. So it's just not possible for the data that are collected routinely to be uploaded and transferred to OHID. We do have usable data in CSDS, not all a disaster, but there's lots of careful cleaning that we need to do. And this is what we've been spending quite a long time doing, creating a research-ready version of the CSDS by comparing it to this external aggregate information that's published by OHID. So this really is our best option at the moment for characterising the health visiting offer by the health visiting contacts, both the mandated ones and any additional ones as captured in the CSDS. But we know that this is imperfect in terms of reflecting the key aspects of health visiting, and that it's also incomplete, although we hope this could be resolvable in the longer term. We have seen improvements in data quality over time. Okay, so moving on to the next challenges around finding suitable outcomes and then attributing changes in outcomes to health visitors. Go on to the next slide, Jenny, thanks. So this figure, it's quite small, but it shows some of the potential outcomes that we're looking at based on logic models of how the health visiting intervention works. One of the difficulties in using admin data to capture these outcomes is about how we interpret the data. So for example, if we're looking at comparing a group of children or families who have high health visiting contacts with a group who had low health visiting contacts, and we're interested in, say, maternal health. What we actually have is data on whether or not the mother was admitted to hospital with a mental health diagnosis. We'd love to be able to link to primary care data to fill some of those gaps, but this isn't yet possible. So we're only really looking at the sort of severe end of maternal health. So secondly, if we're comparing mental health admissions between groups, we might see lower mental health admissions in mothers from families who have received higher health visiting contacts. And that might mean that health visitors are addressing some of the underlying need and supporting mothers to prevent them from having these mental health conditions. But if we see higher admissions in the high health visiting group, then it might not be a reflection of underlying need, but it might be a reflection of the work that health visitors are doing with families to help them recognise that they need support and go to seek help. So it might be appropriate help that they're seeking. Where help in the community is unavailable, then mothers might end up presenting to the hospital. So the same sort of problems happen when we're looking at child hospital admissions as well. It could be a reflection that families are being encouraged to seek medical attention where necessary, rather than a reflection of the underlying need. Okay, in the next slide, I'm going to try quickly to describe what we're doing to address these challenges. So we're doing a lot of work, firstly, to describe the intervention. It's really important to be able to understand and describe what's currently happening, including variation across the country, before we try to move on to evaluation. And for this, we're using a combination of quantitative data, both at the national and local levels, economics analyses on the costs of health visiting services, and qualitative work in a number of case study sites with health visitors, managers and parents. It's difficult. We've seen from CSDS that the quantitative data aren't perfect and need a lot of cleaning, but there is a lot of work, a lot that we can learn from this foundational descriptive analysis. And then secondly, on finding suitable outcomes and impact, I'm a huge advocate for the value of administrative data, but we can also recognise its limitations. And part of what we're doing here is testing outcomes and trying to understand how best to interpret those outcomes that are captured routinely. And the qualitative work is really important for this. We're also trying to identify gaps in routinely collected data that will help make a case for primary data collection. And then finally, we're using a range of methodological approaches, including ecological designs that look at how health visiting is delivered within and across different local authorities, but also propensity score matching at the individual level, using the detailed information we have on risk factors from administrative data to try to overcome some of those issues of reverse causality. Okay, back to Jenny.
Thanks. Sam, do I have time to talk about sort of next steps, or should we save that? I do? Yeah, okay. So, you know, we're in it, as we described, we're using already collected administrative data and generating comparison groups from naturally occurring variation. So we're really picking off the lowest hanging fruit here in terms of the ultimate ambition, which is, you know, the top of this poll here, which is to evaluate the impact of health visiting. And the study designs that we're using are the less time consuming, less expensive than primary data collection and randomizing using experimental designs, which would change practice in some areas and hold it constant in others. For us, we're really seeing these studies that we're doing as the first step in evaluating health visiting at a national level in all its complexity with its variation. And you might be asking, well, you know, you're highlighting all the things that make it difficult. You know, almost, you know, why bother with this? I think we're really seeing this as steps on the way to a long-term goal. So as part of scaffolding up to quantifying the impact of health visiting, for whom, on which outcomes and in which circumstances and at what cost. And along the way, we're learning things about health visiting and its impact, but we're also making the case for what needs to happen next. Sorry, London noise. What needs to happen next and the steps to evaluating health visiting. And we really, as we're going along, we're seeing that, as Katie mentioned, we're going to need to include GP data. So to gather information on lower threshold, so less severe health outcomes. We're probably going to need primary data collection for more immediate, what we would call proximal outcomes, so things like child and parent interaction, rather than hospital admissions and things very far away from health visiting. And we may need to start thinking about using experimental designs where we can take promising approaches or interventions and implement them and measure them in some places, but not others. And I think a key point, and we can discuss this, is how we conceptualize contacts in our research. So that's what we can measure. But the more we work, the more that we see that frequency, location and duration of contacts are not a sufficient proxy for health visiting delivery. And perhaps we should be seeing them as they're necessary but not sufficient. And perhaps we should be thinking about them in research as infrastructure, health visiting infrastructure. And then it's what happens in those contexts and around those contexts that constitutes the intervention and the thing we need to measure. Lots of people involved, including our funders. And thank you for listening. We can move to questions.